Hi, Sarah. Hi, Sarah.
About now, I took out the speaker.
We can hear you now.
All right, so much for technology. I love it. Anyway, Happy New Year, everybody, and welcome to our monthly webinar. As I mentioned earlier, some people had questions about CME. The CME is provided through Queens Medical Center. You'll later this month in January, if you have completed the evaluations that we have for Geri Echo, at the middle to end of the month, you will be receiving those CEUs for physicians and nurses. Joining me this afternoon, I want to welcome our other Hub team members. Along with me, we have Courtney Nunokawa, our nurse practitioner, Chris Vale, who's our physical therapist, Dr. Rita Bell Fernandez, our geriatrician, along with Dr. Lucas Morgan. We're very excited to share our collective experience and wisdom and to also learn alongside you. As I reminded you earlier, the evaluations are required for the CMEs. And you can find that there'll be a link in the chat later on through the webinar, as well as you can also check our website for the link to the CMEs, to the evaluations, excuse me. Currently, we have the CMEs and CEUs for physicians, the DOs, RNs, APRNs, and physician assistants. And we also offer certificates of attendance for our CNAs and students. Your comments are very important to us here because it's useful to the planning committee for future programs. The ECHO webinar forum is one of mutual teaching and learning from all of you as well as the experts on our hub. As the ECHO motto goes, all teach, all learn. And in the spirit of aloha, we encourage you to turn on your cameras. If you're hungry and haven't eaten lunch, please feel free to eat lunch because it's an important part of good nutrition and a healthy lifestyle that we want to promote. Just as a kind reminder, our ECHO webinar format consists of the following. We'll have a short lecture from our presenter today, and then open comments from the subject matter experts on the Hub team. And you, the participants, you can ask your questions in the chat, and you're encouraged to provide any case examples for discussion. Lastly, please keep case discussions HIPAA compliant. This includes not sharing the patient's name, birth date, address, and so on. We learn best from our patients and our clients. They are our best teachers. This afternoon, it gives me great pleasure to introduce my longtime colleague, and it's not because this is related to age, John, but John and I have known each other probably a little longer than I've been married, which is over 44 years. And I'm proud to say that John has probably been the longest long-term care ombudsman in the state of Hawaii, the Executive Office on Aging, that I can remember. And you'll correct me if I'm wrong, John. He's been there since August of 1998. So he's been there more than 26 years, and hopefully we can keep him for we can keep him to complete his 27th year. Prior to being the long-term care ombudsman, Did you know that John was the director of social services for two major nursing homes here on Oahu? He served at Monolani Nursing Center for 2 years, and then he held that same position at Halinani Rehab and Nursing Center for the following 7 years. Besides being the president of the Long-Term Care Social Workers Association for 7 years, he's demonstrated leadership in our community in a number of ways. And there's just two things that stand out in my mind is he was instrumental in being involved with the Surrogate Decision Making Act. And I also briefly got to know him through Jim Peach with the Elder Law Program because John was involved with the Adult Protective Services law that was updated from looking at dependent adults to changing it to what we call now a vulnerable adult, that definition. He's currently a practicum instructor for the UH School of Social Work with both UH, the Hawaii Pacific University, and Chaminade. So without further ado, it is an honor, John, to introduce you. And thank you for presenting today.
Thank you for having me. And I'm glad that you had that little technical problem because that actually relaxed me because I'm always having technical problems. So I'm glad it's not just me. I'm probably not going to follow the PowerPoint as closely as originally intended because I realize the purpose of this group is a little bit different. And so one thing that I want to bring up real quickly is on last Friday, we had the Kapuna Caucus meeting. And the Department of Health is proposing a change that I'm strongly opposed to. And I wanted to talk a little bit about that. When I started in 1998, I was surprised to learn that the care homes and the foster homes and the assisted living facilities are told in advance by the Department of Health when they're going to get their annual inspection. And I thought, how do you find anything wrong if you tell people when you're coming? And that was because I had 7 years or 9 years of working in nursing homes, and they all have unannounced inspections because they have to follow federal regulations, and there are no federal regulations for the other types of facilities. So Marilyn Seeley at that time was the director for the Office on Aging. Bruce Anderson was in charge of the Department of Health. We went to meet with him. He was not aware that his surveyors from OCA were telling facilities when they were coming. He totally agreed with us that that makes no sense. He wrote a letter telling the facilities that that policy was going to change. And lo and behold, the facilities went running to Governor Cayetano, and that decision was reversed. And we had already convinced Susie Chan Oakland at the legislature to introduce this bill. And then all of a sudden I was told by my boss at that time, Marilyn Seeley, oh, we're not allowed to testify in favor of this. And I was like, how come? We're the ones who got the bill introduced in the first place. I feel like, we're kind of leaving Susie on the limb there. And she said, well, if you want to testify, you have to do it as an individual on your own time, but you can't not do it as the ombudsman. And so this is the very beginning of my career as an ombudsman, 1998. And I said, I've read the federal law and I'm testifying as the ombudsman, or I'll testify as the recently fired ombudsman, but this is what I'm supposed to be doing, and you're not going to be able to stop me. And so that bill did not pass for many, many years. It took more than 20 years to finally get unannounced inspections of care homes, foster homes. And now the Department of Health wants to reverse that and go back to giving notice. And we have a new person in charge of the Office of Healthcare Assurance. Her name is Paula Serio. She's from New York. She's only been here about 2 months. She was working in assisted living. I've met her. I like her. I feel I can work with her. And so I'm pretty sure this could not be her idea because she's brand new. Why would somebody from New York say, oh, we need to have announced inspections? So this is from somebody above, Department of Health, that is pushing this. And an example of why this is so important. We have a resident right now with Down syndrome, stage 4 wounds. She was in a care home. She was sent to the hospital. She went to a nursing home. She got very good care, but they discharged her when it was not a stage 4, but maybe it was a stage 1. And they thought that that expanded care home would be able to continue providing the necessary care. They did not. It's now stage 4 again. And this is a family with a lot of siblings. And the one who is the guardian lives in another state and was getting phone calls from the caregiver. Your brothers and sisters are always complaining, always causing problems for me. I really don't want them visiting. So if you can't do something about that, then maybe you need to find another home. So the guardian told the family, you're not allowed to visit. So now we don't know what's going on, but they did send me pictures that they were able to take of the stage 4 wound, and it looks really, really horrific. And if the state surveyors were to tell that home when they're coming for the inspection, that woman will not be in that bed. They'll replace her with another woman who maybe is not able to talk, so she can't say anything. Because how does a surveyor know, is that Mrs. Smith or Mrs. Jones? I've never seen these people. There's no pictures of the resident in the chart. The charting is very minimal. So this is going to be horrible if this happens. And so I wanted to just bring that up first before I go into my presentation, because I'm hoping that we can convince Dr. Fink to kill this before it actually is introduced as a bill. Because then it becomes a media event, it just becomes a real circus. And so we fought too hard to get unannounced inspections, and I do not want us moving back. Okay, so that's my little commercial for today. Next slide. So our mandate is written by federal law. We're part of the Older Americans Act of 1965. We were not in the original 1965 document. We were an amendment that came out in 1978, I think it was. So our job is to protect the human and civil rights of Hawaii's aging and disabled population who reside in licensed or certified long-term care settings through the provision of culturally sensitive advocacy. Of course, in Hawaii, our population is very culturally diverse. And so we have to honor the different traditions and the different ways of talking to residents and their family, making sure that we, show respect. And so this is something that is part of our training for our volunteers. We started the volunteer program in 2001, and we've had well over 200 volunteers, but we definitely need more. Next slide. So this sounds a little bit like we're surveyors. We are not. We do identify, we do investigate, we do resolve complaints. We do not have the jurisdiction to cite. We do not give out deficiencies. So we hope that the facilities will work with us, and for the most part they do, because we tell them that, these complaints, if you don't fix them, when the surveyors come in, now it's on your public record. Now, who looks at that public record? Lawyers who want to sue you, because they will look for patterns, they will look for severity, they will look for scope, the 3 areas that they look for. Our job is to protect the health, safety, welfare, and the rights of our residents. We inform residents and their families about how to obtain services, outside agencies. We would like to see very strong resident councils and family councils. We still have resident councils. Family councils have kind of disappeared for the most part, because some of our administrators are afraid of them versus us, this kind of tension. And that's because they don't have a good facilitator who knows how to run the meeting so that it doesn't become a bitch session. It doesn't become a shouting match. You really need kind of a social worker to do that. Some facilities, instead of having a monthly family council, they have an annual, oh, let's tell you what's happening with the building. We're replacing the roof. The plumbing is blah, blah, blah. That is not a family council. A family council is when families get the right to voice their concerns and find out, hey, I thought it was just my mom who didn't like that particular nurse aide. Now I find out it's everybody. So there needs to be some retraining of that person before you end up having to maybe terminate that person. We're supposed to provide regular and timely access to all of the facilities, all the residents. We have 1,700 facilities spread over the 6 islands. So I have a lot of Hawaiian Island miles. So we've been trying for the longest time to have a full-time ombudsman for each of the neighbor islands. We finally got the governor to approve that and fund that, but applications have been very slow. It's really a hard job to fill because it's a very demanding job. We are involved with governmental agencies, state agencies, and federal, and we are allowed to comment on law. So some people, you cannot talk to the legislature, you cannot talk to the media unless you have some kind of prior approval. You have to register as a lobbyist, all this kind of stuff. We don't have to deal with that because it's actually in federal law that this is part of our job. Next slide. Okay, this you all know, but the public is very confused about what's the difference between a care home and a foster home. When they're complaining about a facility and they tell me, oh, this care home, blah, 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 I always have to stop them and say, what's the name of the facility? And then they'll say, Halinani. I say, okay, that's not a care home. That's a nursing home. Oh, what's the difference? Well, the difference is they have different regulations. I'm going to be giving you the wrong answer if you gave me the wrong facility. So I have to make sure that we're talking about the right type of facility. So you fall out of the bus, you break your leg, you're in an acute care hospital. They want to stabilize you as quickly as possible, and out the door you go. You go to the nursing home, your skilled level, Medicare will pay for that first 20 days, 100%. From the 21st to the 100th day, we have a problem because we're seeing more and more insurance companies that are kicking people out. So there's a reason why Luigi Mangione is right now considered kind of a hero across some parts of the United States, because we have people who have paid into the Medicare system for all the years that they worked, and now finally they're 80-something years old and they're injured and they need therapy, and the insurance company wants to cut them off on the 21st day because then they paid nothing. It was all covered by Medicare. And you go home when you're not really ready, you're going to go back to the hospital. Or you're going to die on the floor, nobody knows, in your house. So these decisions, I've talked to Jack Lewin about this, really need to be made by doctors, healthcare professionals, not the insurance companies. So this is a bill that we might try to get introduced this year, that the decisions about when somebody is being discharged should be made by the medical experts and not by the insurance companies. You get better, you're no longer skilled, you're intermediate. So now instead of the focus is on a registered nurse, it's going to be on a certified nurse aide, CNA. So bathing, toileting, those kinds of things. People get very used to being in a nursing home. And then, oh, the good news, you got better. The bad news, we got to kick you out because you're no longer SNF, you're no longer ICF. Well, where do I go? I sold my home. I've been here for several years. I don't have a home to go back to. Oh, yeah, that's going to be a problem because care homes, for the most part, really only want private pay. They can take SSI, but a lot of them choose not to. And because you're no longer skilled, you're no longer intermediate, so we can't send you to a community care family foster home because that's a mini nursing home. It's the same level of care. So you got to look for some kind of Section 8 housing. We'll call up Catholic Charities, or maybe you'll be in a boarding home. So I would rather kill me now than, have to go through that transfer trauma again about what am I supposed to do now? The assisted living, we know it's kind of a combination. They're all private pay. The only one that was really Medicaid out of desperation was the Ponds at Punaluu, and then it became Oceanside, and then it became Dignity Senior Living, but the state shut that down. And so now from Ann Pearl all the way to Pearl City Nursing Home, there's no nursing homes because Kahuku shut down their nursing home, Crawford shut down, Wahiwa shut down. So you live on the North Shore, you're in trouble. Nothing from Ann Pearl to Pearl City Nursing Home. And then the independent living. So we do have facilities that will discharge somebody to a boarding home. And I get, because of federal laws or federal regulations, CMS, Centers for Medicare and Medicaid Services, they require that I get a copy of every discharge notice. And I review every one of them. And it's well over 500 a week. And so, okay, a boarding home, but this person still needs therapy. This still person needs insulin injections. Who's going to do that at the boarding home? You cannot send somebody to a boarding home if they still have nursing care because boarding homes don't provide nursing care. So, so that's a red flag that I have to work on. Next slide. Okay, so again, where you go, your level of care is dependent on what your level of care will determine where you're going to be living. And so the adult residential care homes and the expanded, the difference between those that people don't understand. Originally, we only had the adult residential care home. Type 1, 5 beds or less. Type 2, 6 beds or more. Okay, I'm in a care home and I had a little mini stroke and my level of care changed. I'm not custodial care anymore. So they got to kick me out. I don't want to go. I like it here. What happened to aging in place? Why can't I stay here? So the Department of Health said if that caregiver is willing to take some additional classes to meet your additional needs, then we're going to bump up that license and we're going to call it expanded. So expanded is a hybrid. So if you're type 1 and you become expanded, 2 of those beds can be nursing home level. The other 3 still have to be custodial level. If you're expanded type 2, 20% can be nursing home level, and the rest have to be regular care home level. And of course, why is a caregiver willing to do this? They can charge more. Why is the resident willing to pay for this? It's still cheaper than a nursing home. A nursing home is $15,000, an expanded care home, you negotiate, maybe it's 6, 7, 8,000. You negotiate. This is the part public does not know. The public thinks that the Department of Health somehow fixed the rates, and so there is no room to negotiate. And so people get screwed all the time. You know, you don't go to that home driving your Mercedes and wearing your Hawaiian jewelry bracelet up and down your arms. You know, you don't let people know how much money you actually have because they take advantage of that information. They would have accepted 6,000, but now they're charging you 10,000 and you didn't blink. So I know you got the money. So, you know, people end up paying ridiculous amounts of money, but it's supply and demand, so they can get away with that. And the aging in place homes. Okay, so again, these are unlicensed homes. Some of them were licensed and they lost their license. And so they turn around and they reopen, but they quietly work with some doctor who gets a kickback to refer these people to unlicensed homes, which is totally unfair to those homes that are licensed and are jumping through the hoops and following the regulations. These people do not have access to the Ombudsman. I can't go into those homes because they would accuse me of trespassing. And if somebody has long-term care insurance and the long-term care insurance finds out that you're living in an unlicensed home, they will not pay and they will ask you to return the money that you gave. So it is a misdemeanor to refer somebody to an unlicensed home. It's a dangerous thing to do. People need to stop doing it. You cannot go into the yellow pages and look up unlicensed home. So we know that these referrals are from doctors, from nurses, from social workers, and that has to stop. Okay, next slide. Pretty much everything that I'm talking about, the Department of Health has done a really good job of improving their website. And so long as you know to go to health topics, then you'll find all of this great information. Next slide. Okay, sometimes people think when we were at the legislature, there were some legislators who didn't like us, and they said, well, don't you do what DOH does, APS? And no, we do not. Adult Protective Services, they're only going to investigate cases of abuse or neglect. Somebody has to call it in. They don't make proactive visits to facilities. Somebody has to call it in. And they have their own intake, so they weed out people. We need to develop some kind of an MOU, a memorandum of understanding, that the people that they weed out, if it's a long-term care facility, tell the ombudsman, I still want to go, I still want to check. Because that resident, if they really were abused, they're now in even more danger. They're even more vulnerable because you ratted on me. And now you're going to pay the price because I told you APS wouldn't listen to you. I told you they wouldn't believe you, but you tried to get me in trouble. So we need to go in there and monitor that kind of a situation. And the same thing with Office of Healthcare Assurance. They go in for a once a year inspection. It's supposed to be unannounced. It's not really unannounced. When Bill Clinton was the president, he said it's an annual inspection plus or minus 6 months so that they can't really figure out. But I go to facilities all the time and they say, oh, we're expecting the surveyors next month. I'm thinking, well, how do you know they're coming next month? Oh, they always come in February. Or, oh, they always come right after Holly Nani. Holly Nani gives us a call and says, guess who's visiting us right now? You're next. So everybody, this inside information, so it's not the way it's supposed to be done. And then they also go in for investigations when they get a complaint. But we try to have our volunteers go in on a weekly basis. So the residents, they get to say, okay, if I complain to you and I made my life more miserable, I know you're here next week. And so you can help me or you can help me get out of here, but you're still going to be around. And that's important to know. Okay, next slide. Okay, so again, this is strictly federal and state law that we have to promote the residents' rights. It's supposed to be a home-like environment. Home-like was anything but during COVID. People were moved all over the place. This wing has COVID. We're moving you to another wing. Again, multi transfer trauma, shock, post-traumatic stress. If you're in a facility like Laliha, the rooms are all rectangular, 4 beds to a room. So imagine during COVID, you're staring at a bare wall, privacy curtain on the left, a privacy curtain on the right. Maybe you don't even have a radio. You're living in solitary confinement. We were still allowed to do our food shopping. We were still allowed to walk along the beach or whatever. But if you were living in a long-term care facility, you had no visitors. How could you not think that this isn't going to impact somebody's mental functioning, not cause depression, not make people want to just, roll up and die. So we made so many mistakes. Hopefully we've learned from those mistakes so we don't repeat them. Let's go to the next slide because I'm looking at the clock here. Okay, so as I talked about, the effects of social isolation, staffing challenges, this is still a big problem. Yesterday was our monthly meeting with our volunteers, or Tuesday, and Kalbi Chartrand was our guest speaker. She's the administrator at the Veterans Home, which of course had lots of deaths during COVID, but she was not the administrator at that time. She's wearing two hats. She's the administrator there. She's also the administrator at the extended care unit. But her staffing, having to hire nurses from the mainland, traveling nurses, and of course they all want to come in the wintertime, and they all want to work, 3 days on, 4 days off. Well, maybe you can do that in the hospital. You can't do that in the nursing home. And so it's really hard to get these folks. They're very, very expensive and they want housing as well. So we really have to figure out how to get more of our own people interested in healthcare. And of course, the Healthcare Association of Hawaii has been doing that. The legislature has been working on that. And the Office on Aging, Executive Office on Aging. So we cannot be relying on the Philippines anymore because a lot of those folks are going to Dubai. And, Arab countries are paying much more than we are. And also we have some problems with our visas, the way that's done, work visas and all. A lot of personal belongings were lost because normally when you go to a nursing home, your family comes with you. They have all of your clothes. The nurse or the social worker says, oh, you've got to put their name on everything because otherwise when it goes down to laundry, we don't know who it belongs to. So it just sits there. So it's not that belongings were stolen. It's that belongings were never labeled because families were not allowed to come into the facility at the time of admission during COVID. So many things that we normally do just, automatically fell by the wayside. And so lots of things were lost. what does informed consent mean when you're talking to somebody with Alzheimer's or dementia? So we kind of, bent some rules in order to vaccinate people. Uh, Having people from a care home or a foster home sitting in a car lined up on H3, shoving a Q-tip up somebody's nose, when they're already kind of intimidated, a little bit confused, it's not comfortable, they're incontinent, it's too tight, it's too hot. It was a terrible way of doing things. So luckily we were able to get these, vans that would go right to the homes and do the testing right there. So we learned quickly from our mistakes, but it was a nightmare, and it's still not fully over. Okay, next slide. Our program. Okay, so I'm a staff of two right now. Actually, three. I have a volunteer coordinator, and I have Jan Mori is my Oahu ombudsman, but I'm supposed to cover the whole state. And so we've got to have volunteers in order to do that. Next slide. So this is our bed count. So we have, now this hasn't been updated in a little while, but 12,895 beds and 1,779 facilities. And so we're supposed to visit all of these folks quarterly. And so that would come out to about 30 facilities a day, 5 days a week, no holidays, no vacation. So not really possible by myself with a very limited staff. Next slide. Okay, so another way of looking at those same numbers, Hawaii is unique in that we actually have more community beds than we have nursing home beds. So we have 4,438 nursing home beds. But the care homes, the foster homes, the assisted living, that's actually totals more, 8,364. So that means a lot more driving, the logistics for the ombudsman program. It's a lot easier to visit one Halinani with 288 beds than ride all over Waipahu, checking on all of these different homes. Again, the mandate is that you're supposed to have one full-time ombudsman for every 2,000 residents. So we should have at least 6.5. And right now we have a volunteer coordinator, we have me, we have Jan. That's it. Next slide. Okay, so what I just said. Yeah, so I've been around since 1998. Jan started in 2023. Lynn's been around since 2017. But our program has always been kind of one step forward, two steps back, cha-cha-cha. That's the dance you do with the legislature. And so we had a volunteer, we had a clerical support, then that was taken away. I don't know why I've lasted this long. I'm just too stubborn. Okay, next slide. So this is the staffing on other states. What I did is to compare apples to apples. I did it by population. There's basically like 13 or 14 states that get the same federal money because it's based on how many seniors you have in long-term care. And the difference, though, is that Delaware jumps into a car. I have to jump into a plane and then rent a car if I'm going to Kauai. So why am I getting the same money as Delaware? Ridiculous. So then you have to count on your legislature to be generous to the program. And as you can see, the states that have very good staffing, their legislatures were much more generous than Hawaii was to my program. But things have definitely been improving. And in particular, because of the leadership of Senator Sharon Moriwaki and the Kapuna Caucus. So we've been really grateful about that. Okay, next slide. So the neighbor islands, we were lucky when Sylvia Luke was in charge of House Finance. She was a strong supporter, and she gave us the money so that we could hire part-time Maui, Kauai, and Hilo. And so then we were able to convert those contractors into full-time positions. Crystal Corpus was our first full-time ombudsman for Maui. And she lasted 8 months. And then she said, this job is just much more stressful than I thought. So I really can't do this. So now we have a vacant position. Kauai, we haven't really had anybody apply for that position. We do have 2 volunteers, and one is a geriatric physician, Dr. Laurel Coleman. So we're grateful that we have them for Kauai. Wesley was our ombudsman in Hilo. He resigned, so we have that position. But again, we do have 2 really excellent volunteers on Hilo. Kona, we've had no applicants. Oahu, Jamel was our Oahu ombudsman. He joined the police department, so he's gone. So we have Jan Mori. So anybody looking for a job, let me know. Okay, next slide. This was our big celebration, and just coincidentally, August the 5th it was the first day that I was hired. So this is when Governor Ige, this is during COVID, so we were not allowed to go in to get a group picture, but the governor was willing to come out and get a group picture with us. And so this was our governor, our proclamation Ombudsman Day, and this was when we were able to get the funding for the neighbor island positions. Get your cake from Sam's Club. It's delicious. Next slide. So you can just see the next slide as well. Our brochures, next one as well. We're very lucky that we got $100,000 from the Federal CARES Act to pay for these things, a toll-free number, logos, polo shirts. We never had any money at all. And so now we have no money again. But COVID was a banner year for supporting us financially, so that was really good. Okay, so maybe I don't know. I guess I should stop. One other case, so that people should know about, is that we have a caregiver who she's a foster home, 3 residents, 1 private pay, 2 Medicaid. The 2 Medicaid, she hasn't been paid in almost a year. This is ridiculous. And this lady had to file for bankruptcy. And so one of the things that I do, people think that I only advocate for residents. Well, I advocate for the caregivers as well. Nobody should have to wait. You're expected to still pay your electric bill, pay your water bill, feed these residents, drive them to the doctors, transportation, those kinds of things. It's inexcusable. And I was told that if the state executive office if the payment is through Department of Human Services, if DHS doesn't pay their bill, they're supposed to pay with interest. That's what I was told, with interest. I haven't found that law yet. I'm still looking for it. But this lady was at risk of losing her home, had to file for bankruptcy, and the Federal Attorney General's office was involved in this. So that's very scary. United States Bankruptcy Court. Luckily now they're actually petitioning to drop the case. But this woman would have never had those kinds of problems if she was getting paid on time. And a lot of our caregivers, 1, they don't know who to report this to. 2, they don't get enough help from the case managers. And 3, they're intimidated. They're afraid of retaliation. If I complain, do I get blackballed? Because I can't admit anybody unless it's through a case management agency. And if the case manager now doesn't like me and tells everybody else don't work with me, I'm screwed. I have a house with a mortgage and I have nobody coming in. So we hear it from everybody. We get calls from case managers, from caregivers, from the residents and all. And we try to help as much as we can. So we're not really taking sides. I mean, of course, we're taking the side of the resident, but sometimes it's really communication problems. Sometimes it's very dysfunctional families that are sending out all kinds of mixed messages. Mom, do not complain because I cannot take you home. I've already told you I've got my own kids. I'm working 2 jobs. You just suck it up. You make the best of it because there's nowhere else for you to go. And so these residents, you can see residents who are just not happy and don't want to be there. Nobody wants to be in a long-term care facility. It happens because of an emergency situation. You broke your leg, you had a stroke, you had a heart attack, and now your life has changed dramatically. And it's not just old people. Uh, I have one case where big, strong Hawaiian guy, but I guess a little drunk and dived into the ocean when it was low tide and fractured his neck and is now paralyzed from the neck down and only in his 40s. So this can happen to anybody. And so we always are trying to get more volunteers to go to the facilities to talk story to the residents because the staff are very busy. Everybody's running around. I don't have the time to sit and hear your life story for 30 minutes. Well, I have the time, because I'm the ombudsman. And that's part of my job to listen to your story and to help you in any way that I can. So that's a little bit, I really only kind of skimmed the surface here about the Ombudsman program, but you only gave me 30 minutes and I took 40. Okay, I'll shut up.
Well, thank you, John, so much for giving us that tip of the iceberg of what sounds like a very complex and very, very challenging and probably often thankless job for what you do. So it's very, we really appreciate you being here. So I'm just going to start by uh, sort of asking our panel to weigh in or ask any questions from their particular fields about what John has talked about so far. And we'll start with Sarah from social work. And I see, Sarah, you did list some questions in the chat, and I don't know if you want to bring those in
Yeah.
now.
Okay.
Yeah.
But I wanted to make a couple of comments. I mean, it was so important that you gave us those case examples and in the end reminded us really the role of the ombudsman is not to be the police. You're not the police. And, I have been able to experience firsthand in working with you, you truly represent the people that are involved with caring for individuals that cannot care for themselves. I really am grateful that there are nursing homes like yourself, John. There nursing homes, the foster, there's a place, right? That because if we didn't have those types of programs, um, my parents are in assisted living and they're declining and one's on hospice, but I think there's a place for sure. Um, the biggest takeaway I got from what you were saying is really there has to be a community effort. We especially in the healthcare field need to take responsibility. If we see things or know things that are happening, we shouldn't be placing people in unlicensed care homes or boarding homes because we just add to the potential problems. So I feel that that onus is on us for one. And the last thing I really appreciated was that you talked about regardless of COVID-19, we still have to deal for our kupuna or anybody for that matter, but mostly our kupuna that have to try to cope with transfer trauma because that transfer occurs not just in between hospitals or nursing facilities and homes, right? It occurs even in the same facility that you have to move. Somebody gets MRSA, somebody has a need for isolation TB, you got to move them. So, and that you also drew upon that this it's the importance of us knowing that people are socially isolated. And Lucas has pointed this out on time again is what leads to that isolation eventually is a feeling of there's loneliness, there's anxiety and depression. So thank you for highlighting those points as well, that we look at the psychosocial needs of our patients.
Yeah, I wouldn't say, and I know you didn't really mean that it's a thankless job. Anybody who's worked with seniors knows they are so appreciative of, everything that you do. And my background as a social worker, I was training to work with kids. And I was working at Catholic Charities during the Interstate Compact on the Placement of Children. And I love Catholic Charities, but the pay is terrible because it's all grant money, soft money. And so there was an ad in the paper for Mauna Lani Nursing Home, and I applied for that. And all of my friends, social workers with kids, that business, they were like, John, you're going to be so depressed. Those old people, you can't talk to them. They all got dementia, blah, blah, blah. And I have never felt that way at all. They want to hold your hand. They appreciate your just being there, just spending some time. And we have this major demographic shift in Hawaii right now that still doesn't get enough attention. Our young people are moving to the mainland. They can't afford to live here. Housing is too expensive. And they say to their parents or their grandparents, do you want to come with us? California, Vegas, wherever. No, no, Hawaii is my home. Across the street there, that cemetery where your father is, that's going to be where I'm going to be. No, this is, I like wearing slippers all year round, you know, and I want my local foods and those kinds of things. And so the kids are not involved, and then out of sight, out of mind, and the visits become fewer and fewer. And so for our kupuna who are so used to this large extended ohana, it is so depressing, so devastating, you know. So I'm glad that the good thing about COVID was that it brought to life all this technology that we really weren't utilizing, you know. So whether it's the FaceTime or the Zoom calls, those kinds of things. And more facilities are setting up computer stations so that residents can see and have a face-to-face conversation with their loved ones around the world.
Okay, well, thanks, Sarah. And you wanna any of the questions you had? So one of the questions I think, Sarah, was that our long-term care ombudsman visits and our volunteer visits pre-scheduled or unannounced when you guys
Unannounced,
visit.
unannounced.
Okay.
When we had for Maui, when we had Crystal, and also for Jamel, because it was their first visit, they did call up to say, "Oh, I'm coming." It wasn't, "Can I come?" That's very important. It's, "I'm coming tomorrow around this time." We do that just because we don't want to surprise anybody. We recognize that people have doctor's appointments. We recognize that you might want to be there to meet us, but you had a substitute caregiver scheduled, and so you want to change that so that you get to meet the ombudsman. And then recently, we've had 3 cases of people pretending to be ombudsmen. They didn't have any identification, and they weren't wearing our orange polo shirt. And luckily, the caregiver, well, at least one of them, did not let them in the house. You know, "Where's your ID?" "Oh, I left it in the car." Walks to the car, disappears, doesn't come back. Okay. So why would somebody want to get into a house? Well, seniors have credit cards, seniors have jewelry. It could be somebody in the family who wants you to sign some paperwork. It could be a member of the family that does a restraining order. And so they're mad at you or they want you to undo something. Who knows? But if somebody says, "Oh, I'm the ombudsman and I need to close this bedroom door and have a private conversation," and so you, the caregiver, a little bit intimidating, "Okay, I guess I got to do that." No, we tell all the caregivers, and we've asked Justin Lamb at OCA, and we've asked Community Ties of America, Angel England, please let everybody know that we do carry IDs, and our folks are wearing these orange polo shirts that do have our logo on it. So, you know, be careful about who you let in. Our nursing homes have always been very bad about security. You go to like Aloha Rehab and you got to sign in. It's mostly because of the parking. We want to know whose car has to move because you're double parked, you know. But almost anybody can get into a nursing home. In fact, just recently, Halima Lama Lama had somebody who was drunk got into their building. So now they have to lock that door to make sure. So, you know, we do have this increasing homeless population, and they're getting, you know, more and more nervy about what they do. And again, you can go into a nursing home and come out with 5 wedding rings very quickly, you know, and run out the door. So, got to get much more serious about security.
Yeah, there's so many layers of vulnerability that you're kind of helping bring to the forefront here. And it's just so important. So for all of us, you know, and I think Sarah mentioned, you know, everybody taking personal responsibility. And before we go on, I wanted to ask, I kind of echo what Renata asked, is what, if we were going to ask you, what would you tell us if we are trying to be supportive of you or supportive of any of this? Um, another, and relatedly, how, I'm curious, how would we get notified of any bills that you are focusing on, and to sort of, if we were choosing to support it and provide testimony, how would we, and any of these ways, how
Right.
could we support what you
Well,
do?
the Kapuna Caucus meets the first Friday of the month, usually from 2 to 3. And anybody who's not on that mailing list should contact Senator Moriwaki, Sharon Moriwaki, and get on that. People pitch all kinds of ideas, and then we kind of vote on like the top 5. And unfortunately, one of the bills that did not make the top 5 was increasing the Medicaid reimbursement for the community care family foster homes. And the reason is because not enough community care family foster homes showed up for that meeting when we were voting, because everybody gets a vote. And so they should have done that, because they haven't gotten a raise in, I think it's like 17 years. So they're getting something like $50 a day. I can spend $50 at McDonald's because prices have gone up, I mean, for 3 meals. So that is something that we need to move that up. It didn't make the top 5. I mentioned earlier about Jack Lewin and I have talked about it's the doctors, it's the health team. I shouldn't see a discharge notice that says discharge determined by insurance company. And that has been increasing, so that I'm not comfortable about that. We love having opportunities to speak to groups like this. I was invited one time to Pearl City Pearl City Public Library, and the woman who invited me said, "Oh, what's your minimum number of people so that you'll come?" I said, "What do you mean?" And she said, "Oh, some people say they won't come unless I have, 10 folks there." And I said, I'll come for one. I don't care how many. I mean, if somebody is interested, then that's what I want to do. That one person could be Governor Ige's mother, you know, because I've had that kind of situation happen where everybody's related to somebody. And what I don't like doing is the senior fairs where you're sitting at a table waiting for people to come. They're grabbing as many of your pens as they can if you turn your back. They just have their basket, and that's when you have these vultures show up, looking for all the freebies. Ask me to be a guest speaker, put me in the corner, I get 30 people the first day, 30 the next 30. Okay, so they got important information versus having to compete with seniors dancing country music style and all of this, overstimulation. So you can't have a conversation. So everybody wants to know, what are you giving away? Are you giving away a free trip to Vegas? No, that's probably an insurance company. We have no money for that. So yeah, so speaking engagements are really, really important. And every year we do go to the legislature a couple of days before to introduce ourselves, because there's always new legislators and there's always new staff. And they get phone calls from their constituents about, a care home, foster home, whatever. And they don't know, who do I refer this person to? So I want them to refer them to me. So I want to make sure that they all know who we are. Robin Matsunaga is the state ombudsman, and so sometimes he gets my calls and sometimes I get his calls. I wish I had his budget and his staffing. But yeah, we don't do prison. Although we have tried to get, the senior population in prison is aging and they're very vulnerable and they need to get out because they're getting beaten up. And nursing homes don't want to take them because they're felons. But they're not of any danger anymore, and they really do need to be placed somewhere. And so that's a bit of an issue. So we've worked with Kat Brady trying to figure out what to do about that. So yeah, again, the Ombudsman program, it can be as wide systems advocacy as you want, or depending on who's in this position, they can be very narrowly focused, but I don't really like that. And we get phone calls. Sometimes it's not our call, but we don't say to people, "Oh, sorry, you dialed the wrong number." I know how to use the internet. give me a minute. Let me search it and see if I can find it for you, and so I can pass them off to something that was useful for them. I get very upset when I'm on the receiving end. You know, I'm calling up a state agency, and they're totally worthless and give me no information at all. You know, so that's not helpful at all.
Thanks, John. Definitely lots of ways that yeah, we can think about supporting all the different things that you've been talking about today. We just have a few minutes left. I wanted to ask Rita Bell, Courtney, Chris from the panel, anyone, any of the panel have things that they want to ask, share in these few minutes?
John, having done lots of home visits in Kalihi and care homes, foster homes, I fully support that these visits need to be unannounced. So thank you. I think we should still champion that. Thank you very much.
And any other folks joining us today have any questions that they've been keeping to themselves? Feel free to unmute yourself and ask. And in the meantime, we did have a question about how do doctors know the status of folks that they might be referring to? And Connie provided us a really helpful link for Department of Health State Licensing Section website. So check that out in the chat. And you can find current licensing lists of lots of different care folks. So, and yep, as a reminder, John just posted a little while ago the evaluation link for attendees looking for CE credits for today. So please go ahead and fill that out.
Yeah, I don't know if the audience received a copy of the PowerPoint, but just to let you know, you're free to distribute that to everybody because we only covered half of it. And so if the other half is of interest to anybody and they want to ask me questions about that, I'm more than happy to talk to them.
Thanks for sharing that. There's a lot of good information in there. Well, John, it strikes me that your role has a lot to do with the person you are. Like you said, another person in your role could be very narrowly focused, but you choose to involve yourself in a lot of different things. Yeah, I just thinking about like someday when you choose to retire, hopefully that's not anytime soon. You know, how to keep this position as sort of invested in the community as you are now. You know, I would hope that it continues that way. So, well, thanks everyone for joining us today. And John, is there a way for folks to access you with further questions from today's presentation?
Sure. My direct line is 586-7268, 586-7268. So I'm part of the Office on Aging. And my email is my name, so John, JOHN McDermott, McDermott at DOH.Hawaii, spelled out, .gov.
Okay, just threw those in the chat for folks. If I got those correct. 586-7268.
586-7268.
Okay.
And by the way, my phone was just fixed today. So if anybody has been trying to call me, I was trying to figure out why is it so quiet? My phone has not been ringing in several days. And Hawaiian Tel figured out that there was some kind of a cross wire. So you guys were getting a signal that the call's ringing and you thought you were leaving a message, but I never got a message and I never got any ringing. But now it's working, so now you can call me.
Excellent.
Thanks, John.
Okay. Happy New Year.
Thank you very much, John. Thanks everyone for joining.